I'll be talking about our joint action, which is being carried out by University of Sussex and Brighton Sussex Medical School in Papua New Guinea, which is working around climate action, healthcare and conservation. And you can see the picture here. We've got the tropical rainforest of Papua New Guinea, which is what we're preserving for biodiversity and also for climate change mitigation in terms of sequestering carbon. And we're doing that by primarily really by treating local people and mobilizing health support for communities which have been previously medically neglected. So I'll start with a bit of context on why tropical forests and climate change are so important to understand together. And then in a moment, I'll go talk about our project in Papua New Guinea and some projects elsewhere in the world too. So first of all, when we're thinking about kind of balancing the climate debt, really, tropical forests are incredibly important. Each hectare of tropical forest sequesters around 300 tons of carbon. And so as we continue to emit carbon emissions, we've got to deal with that. We've got to keep those fossil fuels in the ground. But at the same time, if we want to deal with the kind of built-in already climate lag of global warming, then we need to think about sequestering carbon. That's preserving the rainforests, which are there already, but also expanding forest coverage. And the second thing to think about really with tropical forests and climate change is if we're unsuccessful in globally stopping the level of emissions on Earth, then it's very likely that in the coming years we'll see more and more tropical forests burning. Now, to be clear, they're already burning, but that's primarily through habitat colonization for kind of industrial agriculture, feeding global commodity demands. But as the temperature rises, we're likely to see some areas simply becoming too hot for tropical forests to continue. We've started to see that in some areas already, but it's definitely something to look out for in the future. So that's the global kind of issue, but in terms of locally, then we need to think about forest people's health. So around 50 million people live in forests and most are highly medically neglected. So in the communities which we work in Papua New Guinea, you have to get to a pharmacy, you would have to walk 2 or 3 hours through the forest, cross without bridges a number of rivers, and then drive around 5 hours along logging roads if you had access to a vehicle, which people largely don't, just to get to a pharmacy or hospital. And there's historically no in-community medical care. So these are very medically neglected communities. They're impacted by environmental and external disease burdens. So obviously, think traditional tropical medicine, we're thinking malaria, and that's a big problem in many of these settings, but also external disease burdens. So Papua New Guinea has the second worst combined health-related sustainable development goal indicators in the world, outside the second worst outside sub-Saharan Africa, I should say. But actually, if you break down those data, you see that a lot of the diseases which are contributing to that burden are diseases which were brought to Papua New Guinea relatively recently as a result of 20th century colonialism. Papua New Guinea was one of the last places to be kind of incorporated into the global system. So tuberculosis, scabies, dysentery, all these things were not known in Papua New Guinea before the beginning of the 20th century. And of course, that pattern continues. So this road that's going into the forest, when I see it, I also see diseases coming in. That's ill health on a number of levels, the kind of things that Enrique was talking about, but also, HIV is a problem in some of our communities. And of course, now we're dealing with COVID-19. Now, when I see that road, I'm seeing it going into the forest because, I'm not living in the forest. But from somebody at the end of that logging road in a remote village, they might see that road very differently. They might see it as a way to get out to secondary care, to access pharmacies and care services. And logging companies know that and overtly push logging on the basis that it will give people access to institutions outside of the forest and sometimes even provide clinics for the locally, at least for short-term periods. So desire for health can drive engagement actually in destruction in these settings. But if we switch that around and try and create a synergy, we might be able to provide healthcare as part of conservation and drive engagement with conservation. At the interface between the global and local, we have the issue of emerging disease threats at the forest margins, which Mel already mentioned. So here's a picture of an oil palm plantation, and you can see a little fragment of forest within that kind of monoculture. Now, if you look at the picture below, you can see unfragmented zones and fragmented zones. Fragmented zones have much more edge. So these edges are effectively porous membranes through which you can get species from the domesticated environment, species from the wild environment crossing over. And so We know a very large number of recent emerging infectious diseases have been linked to rainforest destruction, most famously Ebola in relation to habitat fragmentation, logging and the bushmeat trade, but also Nipah virus and SARS-1. Obviously the jury is out on SARS-2 at the moment, but it's very likely it's at least in part related to habitat destruction from expansion of agriculture in northern China, as well as the wildlife trade. Great to hear Kingsley's work on HIV, and it's probably worth remembering that although we think of HIV in terms of the clinic now, its origin is very clearly connected to exactly the same processes, but at earlier stages. So I'd highly recommend Jacques Pepin's book, The Origin of AIDS, recently revised, which shows the kind of brutal intrusions of Belgian colonialism with kind of the growth of Europeanized cities and forced labor in highly biodiverse forests, and the construction of railways really facilitated that spillover event right in the 1920s. So let's think about how to do something about it, kind of planetary health interventions. And I'll talk about the project that we have in Papua New Guinea. So this is on the top, we have the Wenang community. We've been working with them at Sussex University for around 20 years to support sustainable development pathways for them. And as part of that, in 2016, the clans requested healthcare services from the conservation collaboration, including Brighton and Sussex Medical School and University of Sussex. So we got funding from Sussex Sustainability Research Programme to go there and do a combined clinical and rapid anthropological assessment with parallel treatment of urgent NIC cases in 2018. So I kind of led that with a primary care clinician and local in-country ethnobotanists, etc. And so we did focus groups, we did key informant interviews, we did ethnography, and then we also did examinations of the entire community to assess what their real health needs and status was. And obviously we treated urgent cases. This is the first time a medical doctor had ever been in that community in its history. And we used that data to then generate demand for aid money from DEFRA, UK Aid Money Darwin Initiative, and that funded our next 3 years worth of projects on the ground. And the first stage of that was in 2019. I returned with colleagues to do community training in evacuation, trauma care and kind of malaria diagnosis and treatment for this community. So at the time they had no in-community health professionals, so really we needed to empower them to provide support to each other that they could. My background before the medical school was in frontline in the ambulance service and also training in remote settings. So kind of I provided this training and to kind of empower this community as a stopgap before we started introducing healthcare services professionally. And then in 2020, thinking about the SDG Good Health and Wellbeing, number 3, Sussex and BSMS built and has nurse staffed a permanent clinic there, providing full primary care for around 2,000 people, previously without any access to in-community medical services. Also, that includes birth support and a focus on neglected tropical skin diseases, yaws, tinian bracata, etc., which are a real burden there. And it's got quite a large catchment area planned, but beyond what we planned, we're seeing patients walk in sometimes for 2 or 3 days to the site. So we've got a catchment area now of 500 square kilometres, with this being the only major kind of aid provision on site. That's been linked to working on life on land and biodiversity. So it's conserved 15,000 hectares of forest. So this project has enabled communities to turn down logging because they know they can get the kind of sustainable development benefits from conserving their forest, which otherwise they would have to access through taking the income and maybe the logging roads from loggers. We've got a new no impact zone and 3,000 hectare buffer zone we've developed around the kind of Wenang conservation area, which we've established with previous projects, and this project consolidates. And so this is really about indigenous-led conservation. So we're responding to requests and it's led on the ground by the clans there. And then in terms of climate action, so SDG 13, field workers on the ground, these are people from the community who've been trained as parabiologists, worked with our team at Sussex and measured thousands of trees, and estimated numbers of carbon. And we know that we estimate about 3 million tons of biomass are there, and about half of that is carbon. So this is a significant sequestration of carbon, major contribution to climate mitigation. And across Papua New Guinea's forests presently sequester 3% of global forest carbon. And so beyond the kind of local scale that we're working on, this project has been embraced at a national level as a kind of model for indigenous-led conservation and climate action. I should emphasise that at all times, the indigenous communities themselves retain all land rights. So we've talked about this in a couple of publications which are up there, one covering the general kind of conceptual and practical basis of the project, as well as the ethics involved, and also the toolkit for how we did the health needs assessment, which is free to use for anybody working in remote areas. And we'd be happy to help in any way we can with other similar projects. Now, we're obviously evaluating this project. We're evaluating the effect on attitudes to conservation. We're evaluating the effect clinically on community health, and we're evaluating the effect on community composition through biodiversity of the surrounding forest. There's no point running these projects if you don't evaluate them robustly. The next stage is we're going to be going to another area of Papua New Guinea, Mount Wilhelm. Now, this is a climate change transect which Sussex University developed over the last 5 years. It's a 41-kilometre transect, about a mile wide, of conserved land from near sea level to around 3,700 metres. Now, the ecological composition of these settings is very diverse. So at the top of towards the top of the transect, we have snow, and most of it is obviously tropical rainforest. Now, that gives the ability to use this for climate modelling, because as you go up the mountain, it gets cooler, the community composition of nature changes, so we can use changes in attitudinal points as a proxy for temporal changes in future climate. So that's feeding into global climate models, and we want to preserve that space. It's under threat from mining and logging, and also expand the conservation area. So we'll be going there again next year, doing a similar thing to we did in Wenang, aiming to do a health needs assessment, find out what health needs they have, and then build in health clinics and expand the conservation area. And because what we already know about the setting, there's going to be a real focus on the ecological determinants of skin disease, which is a strength that kind of BSMS has. Thinking about other projects, we're by no means the only people doing this. Is going to give you two examples. One, ASRI, which is running in Borneo. Now, that's at the Panangalang National Park. That's a 90,000 hectare rainforest, really globally important for orangutans, for instance, as well as carbon sequestration. Now, the problem there is that 60,000 people live around the park border, mostly very poor with little access to medicine historically. And when they have an emergency, they've needed to go into the national park and do illegal logging just to pay for basic emergency care for them and their children. And if I lived in that community, much as I'm motivated by forest conservation, I'm sure I'd be doing the same thing. So ASRI went there, started up setting up mobile health patrols, and also a health clinic directly linked to conservation and forestry planting. And they've recently published a paper in PNAS, which shows some really significant outcomes and success from a really rigorously evaluated project. Now, at the other end of the scale, there's a lot of these bolt-on projects which add on to existing work globally, which are being carried out by NGOs which never enter the academic literature. So I'll give you one example here from the Royal Society for Protection of Birds in Golan. And this is a RED project, so that's a specific aim to reduce carbon emissions from forest destruction. And in terms of SDG 15, it preserves 70,000 hectares of forest. In terms of SDG 3, RSBB, and let's remember this is the Royal Society for Protection of Birds, built a hospital as part of this project. And in fact, this was one of the first response sites for a major Ebola outbreak. And as I mentioned earlier, Ebola has partly been linked to deforestation and habitat fragmentation. So here we have a conservation project responding to the health impacts of deforestation elsewhere. And in terms of climate, they've reduced emissions from deforestation just in 2 years, around 1 million tonnes of carbon. Now, this project has never been published in the academic literature. We know it through internal networks. And so we're collecting all this kind of unpublished evaluative data and mapping it for an output next year in the Lancet Planetary Health. Now, I've been talking about operationalizing medicine to conserve land and also sequester carbon, but it's probably worth emphasizing that simply preserving tropical forests has real public health gains. So this is some very good work done in Cambodia across 35,000 households. And the key finding really is they found that dense forest loss was associated with an increase in acute respiratory infections and diarrhea, whereas protected area coverage saw a reduction of acute respiratory infection and diarrhea. And these are real global health targets in these communities, and it'd be very expensive to get this kind of effect size by introducing clinics and doctors, things we should be doing, but actually often it's going to be cheaper at the start to think about really using those ecosystem services already available in nature by preserving forests. So to conclude, some broader lessons for climate action and SDG integration. So a lot of the projects we'll be looking at have real evidence gaps. They're projects which have been set up by local NGOs for local needs with no academic input. So there's a real need for rigorous evaluation. Now, planetary health is a vibrant medical movement, it's a scientific field, and the idea of working for both natural health and human health is a really beautiful idea, which I feel I'm committed to. But we should, on a global level, however, we should remain somewhat cynical sometimes, because is health conservation, climate integration on a global level, and this is true for SDGs generally, potentially a Panglossian fantasy? Are we really seeing the best of all possible things in the best of all possible worlds? And I was a youth delegate at the 1995 climate conference. So this conference today is in the run up to COP26. That was COP1. And to me anyway, at that time, it was obvious that global powers were not going to significantly see reductions in CO2 emissions. And actually it's got increased year on year. So we should take action. We should aim to reduce CO2 emissions, but we should also be wary of thinking about things that are achievable on a global level sometimes. But we can still achieve local objectives for today, for health, for biodiversity, for climate mitigation. And this is meaningful to those communities and nature in the future. It's going to enable them to survive a worsening climate, even if global ambitions for climate and sustainability are not realised. And the only way to realise those is to do local action on the ground, both here in the UK and abroad. So in summary, tropical forests are globally important for biodiversity, carbon sequestration and the prevention of pandemics. Tropical forests are locally important for the health of 500 million people. Integrating action on sustainable development goals for climate, health and biodiversity is sometimes effective. Disease prevention through forest protection is cheaper than cure, but we must remain vigilant and somewhat remain cynical about ideas we find beautiful and really want to be true. So robust project evaluation and some level of global realism are key if we're going to make a real difference. Thank you.